I did this a couple times before, and I did it the way I used to, and now I suppose I should start out more with the kind of approach that you're being pushed into this form. But basically, let me go back. What you're looking for is facts. That's all you want to do is facts. You're out to get information. And, you don't want to get into mental health attitudes about, oh, wasn't that too bad, and tell me more about this, or so on and so forth. All you want to do, you don't want them to tell you more about anything unless it's going to help you fill out this form. Because you're not there for a counseling treatment situation. Sometimes it's hard to get that mindset. To do a lot of talks with patients tend to get into issues and try to develop those. This is not the time to develop issues. I think it's probably very helpful to have the form because when you sit down and you've got the pen, it sort of gives the person the idea that you're here to get information. Someone comes in. So it sort of helps to keep them on target. And sometimes you will get patients or families who want to tell you all about everything that ever happened in their whole lives. They're very circumstantial. And sometimes you may have to say, there's just certain information I need to gather for this. And, you can talk about those things to a social worker or the doctor or whoever later on, but I need to get some information, and that's why I'm here, is to gather some specific information, and we stick to that. And you can do that politely, but sometimes you will have to stop it. Otherwise, you'll be there for an hour, and you'll be on the first page still. And you just have to do it. The main thing you want to know, the main thing you have to focus on through the whole thing is, what are the reasons they're in the hospital? You can ask their reason, what you suggest you do. It's the chief complaint. And a lot of people are going to say, I don't need to be here. Nothing is wrong. So for the chief complaint, you either have family giving you information, or you have certificates giving you information, or you have another source of information that tells you why they're here. So the primary focus of the whole thing is to get some idea of why they're coming to the hospital. Now, the why they're coming has to be criteria for being here. Basically, criteria, as you know, criteria are dangerousness to self or to others. So in a sense, you're trying to build, I sometimes look at it as sort of being an attorney. Prosecution. You're trying to build a case. You're trying to build a case to establish that this person needs to be in the hospital. Now, you're not making one up, but you're looking for the information that establishes the fact that this person needs to be hospitalized. So those facts are related to dangerousness. And so you get into all the information that you can gather on dangerousness to self, dangerousness to others. And it's usually going to be dangerousness to self. And you focus on that and draw it out. And I think you need to, again, not gild the lily, not slant things, but you need to look at it as building a case. So if someone has taken a razor to their wrist, you might say they scratched their wrist, or you might say they made a suicide attempt by cutting their wrist. If you say they scratched their wrist, it sounds pretty insignificant. If you say she cut her wrist in an attempt at suicide, that sounds a lot more significant. And again, it's not distorting what they're telling you, but you have to slant it in that direction. I think if you say someone made a suicidal gesture, it minimizes it. If you say they made a suicide attempt, even though they may have just scratched their wrist, we don't really know whether they intended to cut more deeply. So if you say they made a suicide attempt, or they made an act of self-harm and cutting their wrist, they had talked about suicide previously, you really sort of use the information they give you to make a case that this person is dangerous to themselves or dangerous to others. With adolescents, and frequently with a manic patient, denies that they will harm themselves, but their behavior is so dangerous that they present a danger to themselves. The same with adolescents. The adolescent who goes out at night and stays out all night at a friend's house is not being dangerous to herself or himself. But the adolescent who goes out and gets involved with a group of druggies or hitchhikes with truck drivers and has indiscriminate sex and does some other things, drives wildly down the road or steals your father's car, whatever else, that's dangerous behavior. I think warrants the engagement of this book. So I think that's really in a way, that's the heart of the admission, not that the rest of it is insignificant, but that's what we use to establish with managed care or insurers or whoever that this patient indeed needs. So it's important to have that slant in their presentation. Yeah.
Trying to fit the criteria into the admission I had last night, who was a 57-year-old single white female who had a living arrangement with an 80-year-old male friend who had lots of medical problems, including God has done 4 with him recent months, in the last 2 months. Her problem, it sounded like, was that she had a long side history, she is arrhythmic, and she had fits of anger where she would scream and curse and verbally abuse the 80-year-old friend, who, and she was not able to really come up to the care level that he required, nor could they afford to have nurses come in. And she herself had a shopping bag full of medications, which she stopped. Now, with that information, I was determining that she definitely had depression and ineffective coping mechanisms. But I glanced at Dr. Taylor's Axis 1 diagnosis, which was schizoaffective. Now, what the question that comes up in my mind, what in her behaviors dictated a more schizoaffective instead of just major depression?
I have no idea from what you said.
Probably carried that diagnosis. I don't know.
No idea. Was that a prior diagnosis?
I didn't get a chance to check because I turned over the admission.
So if he knew her or knew that she had prior diagnosis of schizoaffective, then schizoaffective was obviously an affected episode, but she had a diagnosis still.
Because I was trying to fit, perhaps what he was seeing was putting the friend's life in danger, because I didn't really see her putting her life in danger. She's still in therapy, though she goes in frequently. But I was trying to fit some danger in there.
What medicines is she on?
She was on Nalvain, primarily Nalvain, Synthroid, Cordura for blood pressure. Those were the 3 that he picked out of the bag.
Suggested schizophrenic.
Also, the fact that she had stopped taking her medication,
And
it can be, actually, it's one of the reasons that managed care easily will deal with an admission if someone with a diagnosis like that has stopped taking both their psychotropic and medical medication is putting themselves in some danger
Yeah.
and certainly showing poor judgment because that is their choice. And you would have, I think you'd have kind of a split there if she came in as an involuntary patient and he went to hearing trying to sell the hearing officer that by merely not taking her blood pressure pills, she was a clear and eminent danger to herself or others who probably would be able to do it. To justify a voluntary inpatient admission would probably be workable or something like that. And that's real worthwhile information for me to have with managed care because their hope is that we can stabilize them on medication and discharge them to a less restrictive intervention. If they're not compliant with that least restrictive intervention, then that bumps them up to the next one.
And that's suggested on the criteria sheet, that lack of insight on willingness or inability to adequately care for one's physical needs. So, not taking medicine that they need to take. Or even if they're psychotropics, they're fairly likely to deteriorate. You just want to take psychotics, arrhythmia, whatever. That contributes to their dangerousness.
So an indication that she, or a verbalization that she's not taking the medication, looking at the facts, which is not as much.
Yeah. So you need to know why they're here, and then you need to know the course of this present episode, and that's your second paragraph, onset and course of symptoms. And you don't have to go into great detail, but you want to give some idea of why this person is deteriorating and over how long a period of time. And whatever, again, contributes to showing that there has been a deterioration. Now, maybe sudden. They may have gone to work yesterday and everything was fine. And then they got terribly depressed with the psychotic episode or manic episode or whatever. So there may not be any great course of illness. And you can just say so. But if there is, if there's some evidence that this has been coming on, what have they done to try to help it? Have they seen any evidence, etc.? And what are the, how is this disturbing their life? And that, of course, is for the psychotics, but the depressed patients, sleep patterns, interest in activities, going out, friends, have they gone to work recently, all the things that, a person typically stops doing when they get psychiatrically ill. You know these things from working with these patients. All you have to do is sort of reflect on what's likely to have happened to this person prior to their coming in and ask them the question. It's probably kind of scary to sit down and do the admission that basically you've been doing all of this work. You're working with patients. You're talking about the same things in staff talks. You're just trying to get the information out in the staff talk that you want to get the admission. The potential for suicide, the at-risk behaviors is fairly straightforward. You could just follow the form. I don't like the form in a way because if it says, intent, no, you have to say yes or no. You can't really sort of couch the answer a little bit on the terms. So, they may have had suicidal thoughts in the past week. And if you ask them if they have suicidal thoughts now, they say no. I would focus on the fact that they've been having suicidal thoughts for a period of 1 week, 3 months, or whatever. If you ask them, are they suicidal thoughts now, and they say no, you're kind of getting stuck. So I would say, have you had suicidal thoughts in the past? How long a period? And I think I would probably, even if this I'm not having them now, get right in has been having suicidal thoughts for the past 2 or 3 weeks. Because again, you're building the case. and you're not distorting the facts. You pull out the things that are important. And you also know that a lot of patients when they're in front of the hospitalization will deny everything. They didn't try to hurt themselves. Big gash in the arm, but they didn't mean to hurt themselves and kill themselves. Same with aggressiveness. And of course, with the adolescents, a lot of them, we do admit a number of them just aggressive features as much as the suicidal features. Like they're threatening parents, grandmother, we've had recently, peers, and that's goodness is free. Prior care is important, and we can see in therapy. So we need to know the chief complaint right here, how that developed, and also what's been done about it. We had a new treatment recently, and then recent treatment, but current episode, not the past history, so it just flows from the natural. And again, the kind of thing that I'm sure you think about when you talk to patients and staff meetings. You hear these things, what happened 5 years ago, 10 years ago, 19 years ago, what this has to do with the current admission. So you're just trying to pull it all together in a neat little package. Current medications are important, of course. This is all pretty straightforward. I guess I'm not a stickler on family history. I always social workers, but you need to get some family history. And it is important, and particularly the history of psychiatric illness in the family. It's very important. It's important to diagnosis. It's important to treatment. You know that. So again, you're just sort of applying the knowledge that you learn. History of suicide, alcohol, drug use. Legal history, educational history. I was looking through an admission today, someone who was recently admitted, and much of what was under chief complaint was just repeated over and over again. And they wrote it out in the legal history. You could probably just put see chief complaint, which is going to repeat the same thing. Actually, the at-risk behaviors frequently. So if it's a question of you're writing out another 3 or 4 sentences, it's already been done. I would just put refer to. The past medical history, of course, is important. Allergies, important. The mental examinations, got to do that. And he's also going to do the many mental. The diagnoses you will typically get from the admitting physician, Paul, and that's usually pretty simple over the phone. You just sort of tie into the chief complaint. If they've had a past psychiatric history, they know the diagnosis, that would be important to know. The other thing is that the admitting diagnosis is not cast in stone. On occasion I've changed it the next day on this form, which would be good. Or I change it on my progress note the next day, a couple days down the road. So, but it's important to have one. It's important to give the doctor on call sufficient information to help with the diagnosis. And typically it's going to be depressive illness of some kind, or sleep training illness of some kind. Those are interesting to know about the diagnosis. How many people get admitted with depression diagnosis?
I have it on my computer if you don't want to know.
The percentage is 60%, 70%. And the axis 2 and 3 probably, I didn't do much with it on the telephone. Axis 4 and 5. You asked the doctor?
We got all of
those. Well, again, we'll come up with something that seems right. Axis 4 is pretty vague. Axis 5 is more vague. Criteria for the global assessment. Some people do admission with the GAF 45. I wouldn't admit anyone to what I would call a GAF 45. And 25, 20, 15, somewhere there. But, the criteria for admission, this page. Now, either I usually do that last because then you have the information you need to tell the chief complaint at-risk behaviors. You've got an idea of deterioration of the present episode. Then you have the material here. I have always thought that this page was redundant from the other work. I don't know why this is needed, but I'm told that it's needed, so you have to rewrite some of the things you've written before here. And there you do need to rewrite first. What do you do with it?
Well, I think it just more clearly forces people to spell out, after you finish the whole admission, that really does force you to put in, those are pretty much the accepted standards for admission to a hospital. So if you go back and you can only come up with one word and maybe one of them, then maybe you need to look back, or the physician needs to look back to say, is this really reasonable admission? The other thing that we find on these frequently is this page does not match the admission at all. And that's where you kind of, for us, almost start to wonder what happened. On one very specific one, it said that the reason for admission was the patient was inappropriate for outpatient due to their level of suicidality. There was no indication in any of the admission note of any past or present suicidal ideation, plan, intent, gesture, nothing. So that's real important to match. Now, what that says to me is that somewhere along the line, someone received information filling out that back page that someone didn't have when they did the first part of it. So it could have easily happened if someone went back to fill out that page and thought, I don't know indications. And then dug a little deeper. As that one turned out, the family said that they thought the patient was suicidal, but that didn't show up in any of the admission anywhere. So that's pretty much what the purpose of that is. I think it's to kind of force you to put in neat little boxes why you would justify, keeping in mind that sometimes we are taking a human being and putting them in the most restrictive form of intervention we can come up with other than jail. And in a lot of cases, we're doing that absolutely against their will. The admission form is basically the form that would be used by everybody. After you guys are finished with it, I have no idea how many people use this form. It's sent out of here on a daily basis to attorneys. Judges see it during involuntary hearings and hearings afterwards. 2 years down the line, it can go to litigation as to whether or not it was an appropriate admission for the person to have ever been admitted on 2 physician certificates. Or liable, even if there were 2 physician certificates, if we admitted someone, if we can't sell them at that time, we saw them in continued danger. So the form itself is an extremely important form that everyone looks at. So I think it's almost trying to force people into truly looking at the gravity of the situation. If the person is not checking into anything, even if they're voluntary, this is a locked-door facility, and in this state is considered the most restrictive intervention we can offer. So someone who just wants to be admitted technically shouldn't be admitted. They couldn't come up with criteria to be in here themselves, and for some reason this themselves should tell you that they're having a problem, but we're mandated by the state as well as the insurance companies and the Joint Commission to meet the criteria that we've set for ourselves. We're an acute care inpatient laboratory-like facility, and merely by virtue of our license have to meet those requirements. So you're kind of the first step in trying to do that. I think that's why if you feel like we're coming down on you, then it's the amount of people that see this, so that referral sources get it, a word that they can't understand. In 2 years, should this be called into court, will you remember what the word was? A document that doesn't appear professional, that has a lot of scratch outs or whatever it is, half-written sentences. We talked the other day in the meeting, and it wasn't until Dr. Kirshner said something that the reality hit me. As a nurse, I think I would be looking at this as a very useful worksheet. And I'm not sure that I would really realize what that paper was becoming. And as I was talking to the patient and trying to maintain some eye contact and doing all the things that as a nurse I feel I should do, I would probably catch myself putting, sleep poor, cut wrist, as opposed to thinking that this is now becoming a legal document that will, by state law, stay in their folders for 20 years. Have everyone, including the patient, have access to it. So it takes that, and until Neil had said something, I'm not sure that I would have thought of this situation.
I think it would be hard for me to work with this form, because when I get permission, I just take a notepad and ask questions, put it all down, and scribble it. Attach one part to another, and the rest of them put it together. And this form, I must admit, it was helpful. It annoyed me at times to have to say what I already said, but at times it would remind me of something that I hadn't put in the patient. The patient may have said, I tried to kill myself 3 years ago or something, and I hadn't put that in the other part. Here is that. But I think you're right that I would find it difficult to do it with the patient present. But I guess if you train yourselves that way, I think it will help to move it along.
Well, it is very useful, and it does give a lot of prompts on the specifics.
Yeah.
And I guess that's where managed care comes in, and we hate to use that as the end-all and be-all. To be perfectly honest with you, most of the managed care criteria is the criteria that we should have ourselves. So that we use in UR, we use the admission notes for multiple purposes. One is that we're trying to make sure that they've met our own internal criteria, as well as criteria for Medicare and medical assistance. And then somewhere within the first 24 hours of admission, sometimes I'm sure there'll be some of you who talk to managed care people, they generally give us an interview period of 15 to 45 minutes. Champus gives us 45 minutes in which to give a review. They use all 45 minutes of the time that they've scheduled for me to give a review. You're probably thinking, how can you get 45 minutes out of that form? Well, they eke it out of you. Some are very specific. I need to know what the patient ate for breakfast. I need to know precisely how long they slept the night before when I give a review. So, and for that I usually get, for my efforts, 1 or 2 days extra time. The questions on these are very typical of what a managed care reviewer will ask me. In that case, I would say err on the side of slightly more detail. I can't say that they took an overdose of pills. It's not acceptable. I need to know how many pills, how did they get the pills, were they their pills, were they their parents' pills? Did they go to an emergency room? Did they have to have their stomach pumped, or did they merely wake up not feeling well the next morning and tell their parents that they had taken some medication? So when I'm doing a review with them, they're always asking the, yes, but, were they an outpatient therapy? Who did they see? How often? Were they cooperative? When was the last time they saw them? Medication? What's the dosage? And some of that is things that you're not going to know, and that's what's been helpful in some of the admission notes when the people have written in, patient saw someone briefly 2 years ago, does not remember their name. I can give that information. If it's blank, I obviously don't know, and then I would call people to ask. That's where legibility for all purposes comes in. And that's real tough, because people are writing in a hurry and they're used to writing in their own particular handwriting. We're all aware of at least one physician here with very difficult handwriting. So that can get kind of tough. I don't know whether the patient has got a shotgun, a shot glass, a shot seat. I mean, I'm sitting there guessing that I'm hoping I'm coming up with the right information. So looking at it kind of with a jaundiced eye yourself and thinking, this is tough. We're also selling somebody on the fact that they're going to be paying over $1,000 a day to have their patient in here. You bring your car in to get fixed, and the person will tell you what's wrong with it, how much it's going to cost you, what they're going to do to fix it. You're going to take your car elsewhere, and I hate to put it in those terms, but that really is the way it is. They want to know what they're getting for their money, what that patient's going to be getting for their money, and whether or not this is the best place for them to be. And that's pretty much what they're asking for us to do. The other question that they will ask me, and I think Dr. McAllister touched on, is what was the precipitating factors? Is this a kid who's always been in trouble, or did her grandmother die 2 weeks ago and that was the only support system that child ever had? As a nurse, you know how important it is, but you may not think to write it on there because who'd want to know that information?
I want to know how this episode developed.
And sometimes there is nothing,
Yeah.
You can trace a child from about the age of 2 when they didn't sleep through the night, and there was nothing that triggered this in the last 2 months. They've just a terror. The typical review for me will be when they start out, they want to know where the patient came from. Did they come from home? Did they come from an emergency room? Was it an emergency? Was it voluntary? Was it 2 certificates? What got them into that amount of trouble? Who referred the patient here? Who was their prior therapist, outpatient and inpatient? If they had any prior therapy, what led up to the admission? Suicidal, and again, very specifics. Did they require stitches? Did they have their stomach pump?
So they want to know whether they were just scratching.
Well, I agree with what you said. If that admission note says patient scratched their wrist, that's what I'll say. But that can be interpreted, did they scratch their wrist in a suicide attempt, or is this a self-mutilating behavior? Both are fine, but it's hard to know which is. Now, if I get something that says patient cut wrist, it does help to know if they had stitches or, because sometimes I'll say patient severely cut wrist in a suicide attempt. But I don't know whether or not they came from the murder. Sometimes it'll sound like they probably had some medical treatment. Homicidal the same way, who did they want to get? Or did they have access? That's the other thing. There's one company that even if the patient said that they were going to stab themselves, they were going to stab themselves on a Thursday between 7 and 8, and they had this whole plan worked out. Their next question is, well, did they have access to something that could actually do that? Personally, I think we could all get a hold of a knife, but there was one admission that the man had threatened to shoot himself, but he was a gun dealer. The information that he was a gun dealer was very helpful because it became very obvious that not only did he have access to it, but there were legal implications and there was other people involved, and someone else who says, I'm going to shoot myself, but probably has no access to it, let alone being special forces or whatever it was. It really does put a slightly different flavor on it. Again, eating, sleeping, I usually get that from they'll ask me on admission what kind of things have been going on with that. Again, I think frequently they're following the DSM-3 criteria, but there's been, Dr. McAllister said, lack of concentration, whatever, some of the props that's in there. Because they have their own little computer screens and their own little forms that they're filling out as we're going down. So the more that they check, some of them have so much that as they fill it out, the amount of yeses that they have will trigger a score at the very end that will tell you how many days they can give initially. Some of them are very nice. And we'll sit there and say, "Why not get many days out of this?" Is what you're trying to tell me. So they're, not all of them are ogres. They're doing their job, and I would say most of the time that's the case. I always have to give them all 5 of the axes, what their discharge plans are. I think in the beginning I was a little calling for the discharge plan because people were using nursing criteria for discharge planning.
What do they look for in terms of, you asked that question, what do they look for in terms of discharge plans? On this sheet, initial discharge plan, stabilized to return home, stabilized, whatever.
That's pretty much what most of them are looking for. A lot of them will be looking at,
Follow-up therapy.
if this is the 4th time an adolescent has been admitted to our facility, and each time they go home to their mother or father and it doesn't work out, then along the line they're going to be wanting to see that somebody is at least looking at what the alternative. If the child is coming in with being sexually abused by the father and the father is going to be continuing to be in the house, they're just wanting to see is someone looking at that, this child is not even going to have the benefits to stay here for 7 or 8 months. So will there be some alternative plans? But generally, home without patient initially is more than acceptable to all of them. They do look for an estimated length of stay, and most of them have the dignity to sort of laugh when we ask that question because patient's been here 3 hours and they're asking for an estimated length of stay. Typically, I say, regardless of what that form says, I generally say an initial length of stay of 5 to 7 days, knowing exactly how long our people are staying. It's 5 to 7 days. Because it's pretty rare for us anymore, even in the adolescent group, to get people that long. Some of the insurance is just merely crisis intervention. And that's all they turn to, and once the crisis is over, they're not implying the patient's not sick. The only thing they have benefits for is crisis, at which point they're looking at a 2 to 3 day length of stay. And once that initial crisis is passed. So if I happen to know that, I don't even bother mentioning the 10 days because I need to contact practice. They want to know what their status is, and I always get that off the doctor's sheet. They got a sheet. Have we ordered a urine for drug screen? If that looks like an issue, or they will put on precautions. Were medications ordered at the time of admission? Before, and then I have to follow that through for the rest of the review. And that's pretty much for the admission. So truthfully, if you're sitting there filling out that piece of paper thinking, who is going to be looking at this crap? Everybody is going to be looking at what you're filling out. I would say that it's the one thing that you will write in your life, other than maybe that 2nd grade report on what you did on your summer vacation, is read by everybody.
It's very reassuring, isn't it?
The good news is that at least it is the one piece of paperwork. As nurses, you do a lot of paperwork and you think, this is just going to be thrown out when I'm done, and nobody's going to care, and what difference does it make? In this case, I will say that yesterday we had ours perused by the administrative law judge and the public defender, your friend. They, and we do for appeals processes, and I think we do also go out to the not to scare people, but
one area you have to be a little cautious about, really probe when parents bring a teenager into a hospital. Because their view of this disturbed kid will be a lot different than the hospital's view. And that may be true with young adults as well, or even older adults whose parents are still very responsible, 30 and 35. And they may tell you that this person is going to kill themselves, and maybe they are doing drugs. And I've done some outpatient evaluations on kids, and it really comes down, did this kid did he say he was going to kill himself? Did he say he was going to harm anyone else? What did he say? Tell me exactly what he said. And, it'll often just sort of fall apart. His father recently, he said he was afraid his daughter was going to stab him. What happened? Well, I was sitting at the table working on some books, and she was in the kitchen washing the dishes, and I looked around, and she had the butcher knife, and she was sort of having the butcher knife. But a little later, I looked around again, and the same thing happened, so I moved to the other side of the table. Well, he presented this as a threat on her part to kill him. Well, that's not going to stand up anywhere. He might have been scared of her, and I think he was, but I doubt that he had any real reason to. But I'll tell him, just point out that these do not meet criteria for admission. Say that dangerousness, actual dangerousness, intent to hurt themselves or someone else, very clear intent for some kind of behavior they need to accept. Of course, there requires, she has to overdose before she can be admitted. I mean, actually, no, she doesn't have to overdose, but there has to be some clear indication that this person is bent on doing themselves harm against someone else. Frequently, their position will fall apart if you scrutinize it very carefully.
We've all had patients who have been released from heroin, and people have said, I just don't understand how these patients can be released from heroin. They're so sick, they need help. And the public defender put it well once for me, which was there's nothing in the state of Manor that says you do not have the right to be crazy. As long as you're not appearing imminent danger to someone or yourself. You can't force someone to have treatment any more than you could force a 400-pound woman to lose weight so she doesn't have a heart attack. You can't force them onto someone. But that is a difficult concept, I think, for mental health workers, because you know that maybe if they got some help or they took their medication or they did whatever it was they were going to do, they would do better. And we've had people leave here in their pajamas or looking very, very sick and just know. I found out the other day that one patient we had released from here and lasted 12 hours. It was an emergency room. The judge said truthfully, and in his opinion, it just couldn't come up with it. And eventually, the patient actually signed voluntary and then the facility and stayed there. And sometimes that's what it takes. It takes a couple of times of people coming in and doing it. It's a hard concept because you're selling more than just the fact that they can treatment, but they can acute care, lock door. It's a little tougher, and I think especially for panicky families. They're scared. Don't want to see their loved one sick or kill themselves. We have a hearing officer. Public defender came in. It was not unusual. And when the public defender came in, she said she hadn't seen him in a while. It's been about a month since another facility that she knew. And she said, do you remember the person who talked to me to discharge him? He said, yeah. I said, well, that night at about 1 o'clock in the morning, I got a phone call from her mother, and they were taking him out. She killed herself. And she said, you're visiting again. So they have their own, trying to weigh the law, trying to weigh what we're saying. We've all seen horrible-looking certs that you knew the patient had done all sorts of terrible things, not in the certs, and that's where documentation from the outside and from the inside becomes really important. But these things happen, and, it was comforting at least to see it from that side that they struggle with their decisions as well. And so I would tend to say, on the side slightly more detail, but again, you're right, that rewrite something over again and feel like you're putting in things that are real subjective. So for rewriting the balance schedule, it's work that mostly they've been doing all along. It's just a slightly different format for slightly different.
Yeah, I've the other times I've presented this, I've tried to make you feel comfortable with doing it. But Lori, I don't think that much. Make you just uncomfortable.
It wasn't until it
I
hit
think
me
it-
the other day that I realized I'm not sure that every nurse out there realizes who's going to be reading that paper. And you do look at it slightly different when you know that. At least I do.
Well, I think on the other side of it, you use your judgment. And that's all you got to go on. Basically, you use the physician's backup. I don't know. I suppose both you and the physician will carry the responsibility for the admission treatment. But if you have sufficient statements in there, sufficient facts to indicate that indeed your judgment, this patient appears to meet the criteria for admission, then I don't think you have to worry about it. But it is important that at the end of it, I certainly agree that you have to have enough there that this looks like a valid admission. I still think you have to build a case in a sense, but you have to build it on reality, not pretense. You emphasize the strong parts, and always carefully you try to tear the case apart. And every time I talk to managed care people, I always focus on anything that's happened that's been negative to the patient. They said in the morning, I wish I were dead because they didn't like their breakfast. I'm going to tell the reviewer this morning, this patient told me she wished she was dead. And maybe an adolescent complaint. How many adolescents don't say that? Do say that. But you focus on that part of it. And, if you use your judgment, you can back up. That's all you have to do.
The good news is I don't think we really have many admissions that are denied. They generally don't even get here if it's that early for managed care. Now after that, but I think most places will usually give us at least 24 to 48 hours to do an evaluation, only to protect themselves for liability too. So, nothing. I apologize if I have scared people. It's just it hit me so badly the other day when I was talking about using a computer that I realized, and maybe it's just me being naive, but I don't think it would have hit me that it was going to be what people were going to be looking at. So, all you can do is write what people have said and the information that you have. And I think you said it the other day that people needed to be reassured that occasionally there will be admissions that are denied. They've been denied long before nursing was doing them.
Involved medications.
And again, as a liability issue, we'd certainly rather err sometimes on the side of admitting somebody who maybe in our hearts at 2 o'clock in the morning would likely needed to be admitted. And if we discharge them the next day or something else, well, it's a far safer thing to do than, I think the administration could be supportive of that. We still haven't had many, but each of the doctors had a couple.
Any questions? Probably after we've done a couple of these, but have you done any?